presentation is about the growth opportunity is that survival cancer can give, and the way that deep learning can give you an advantage in predicting cancer risk. Before getting to the main content, I would like us to get to know each other better. Let me introduce about myself first. I'm a Master of Public Health and also an AI researcher at Moa Data, South Korea. My focus are statistics, cancer risk, and prevention. Especially, I'm interested in the integration of AI in survival analysis for addressing healthcare problems. My role in this research project is data analysis and writing paper. So now I would like to know more about you. Most of you must be health specialists, so I guess you know well about cancer. However, I'm curious about how many of you are familiar with AI terms such as deep learning or machine learning. Please give me thumb up reaction by clicking at the button at the bottom, or any reaction that you like. Could you give me some reaction? I can see to your screen. At the moment, see no one raise a reaction. Okay, Dr. Sucharita. I guess that most of you are not familiar with in AI field, so I will give some context about it. Thank you for letting me know. I will move on. The first context that I would like to give is our research subject and also our main study technique, survival analysis, and also deep learning. For research subject, we selected 10 cancer sites to study considering incidence and mortality, such as gastric, breast, lung, or liver cancers. The next conception. Many of you must be involved in cohort of follow-up studies in healthcare. Survival is often applied in those studies to understand and predict patient outcomes over time. Survival analysis can handle censored observation effectively to model time to event data. Traditionally, Kaplan-Meier or Cox proportional hazards are common for survival analysis. You can see the plot at the right side. It illustrates the typical follow-up data for survival analysis. There are uncensored observations where the event of interest has been fully observed. On the other hand, censoring occurs when the event of interest has not been observed for some participants by the end of study period. Now, what is deep learning? First and foremost, what is artificial intelligence? You may have heard about AI a lot. It is a broad term including several disciplines, and machine learning is a subset of AI. It includes unsupervised learning, such as K-mean, supervised learning, such as SVM, or reinforcement learning. Among them, deep learning is a branch of machine learning with high flexibility, meanwhile less assumption. So, enough talk about context. Hope you are satisfied. I can't wait to introduce you about our study. Initially, we realized the gap in published literature. Until now, most common survival analysis technique is cost-pH due to its high interpretability. However, it relies on strong assumption on constant relative hazard. Due to the flexibility of deep learning, recent studies suggested survival neural networks outperform traditional techniques. There were 3 phases when conducting this project. The first is data collection. Our study used data from Korean Cancer Prevention Study 2 Biobank, which is a national blood-based cohort consisting more than 160,000 observations. The follow-up time can be up to 16 years. We utilize demography, anthropometry, and biomarkers data for our research. You could have a look at the features that we use for our research. I will pause some seconds here for you to observe it. At the feature processing step, missing and irregular values were addressed. Datasets for training, validating, and testing were also defined, and so on. In data analysis phase, cost regression and 4 neural networks were compared for performance. Among them, the last 2 models were introduced by our study team. The evaluation criterion is concordance index. For hyperparameter tuning, we applied TPE, the state-of-the-art optimization technique. Among the 3 phases, I was engaged from this process. The training process can be visualized by this plot. Data was split into 3 sets: training, validation, and testing. For the inner loop, we focused on iteratively updating model parameters using the training set and validation performance with the validation set. For the outer loop, we involved selecting the best model based on validation performance and then testing it on the test set to ensure it generalized well. On the right plot is the architecture of our proposed model and the model takes advantage of long short-term memory layers. In short, LSTM are a type of recurrent neural network, are powerful for sequence modeling due to their ability to maintain and control memory over long periods. For multi-LDIP, which you can see below, we further apply multitask learning for improve the performance. All right, with those techniques, how did our models perform? First, let's have a look at number and distribution of cancer cases. The most common cancer size had more than 3,000 cases, while the less common have around 300 cases. Here are the optimal hyperparameters obtained after completing the inner training loop. Though hyperparameters include learning rate, optimizer, number of epochs, and dropout rate. These are the visualization of hyperparameters tuning process. As can be observed, the values are easy to converge, suggesting the advantage of our models. Really, I will show you how the models performed based on C-index. The higher C-index shows the higher predictive power. For better clarification, our models are represented by the warm tone, while the other models are described by the cold tone. Tipit and cost regression have the equivalent pattern of C-index. NDIP and multi-NDIP achieve the consistently high C-index and outperform other models on most cancers except for prostate and liver cancers. Actually, the lines of NDIP and multi-NDIP nearly overlap because the performance of multitask version was just slightly improved as compared to NDIP. For more details, please refer to our published paper. In conclusion, we introduced NDIP and its multitasking version for predicting cancer risk based on clinical biomarkers. We used health follow-up data as input sequences of recurrent neural networks, enabling high predictive performance. Our model can assist healthcare providers in determining people at risk of 10 different cancers. Furthermore, what I hope is health practitioners and specialists are motivated to involve modern technique, particularly AI practice, in healthcare research. Thank you for listening. I am looking forward to your collaboration.
My topic from the following 5 aspects. Part 1, Introduction. Neuroendocrine neoplasm, NENs, are both aggressive and real. Recent research has shown that NENs are most commonly found in the lungs, followed by the gastrointestinal system and the pancreas. They can also occur in unknown primary lesions, which may include the uterine cervix. Cervical NEC has a high malignancy rate, a high fertility rate, and a poor prognosis. HPV infections are related to cervical NEC, specifically with the HPV strains 16, 18, or 35. Additionally, smoking a cumulative radiation dose of 50 GY and the absence of brachytherapy have been linked to the recurrence of cervical NEC. Yes, we can see this disease is uncommon in the female reproductive system. The 2020 WHO classification of NENs categorizes them into 2 groups: neuroendocrine tumors, which means NETs, and neuroendocrine carcinomas, which also calls NECs, which is different from the 2014 WHO classification of NENs. The terms low-grade NET and high-grade NEC have been removed from the new categorization, considering that NECs are frequently linked to adenocarcinoma. The term carcinoma admixed with NECs have been preserved in the 2020 WHO classification of NENs. And part 2, pathology. The next page. Cervical NEC can manifest as an erosive, cauliflower-shaped, or unclear-like growth. It is usually gray-white or gray-yellow and can penetrate within the cervix to become barrel-shaped, similar to squamous or adenocarcinoma. The nuclei of SCNEC are quite large, densely hyperchromatic, and have unclear nuclei that are often accompanied by necrosis. Both mitosis and necrosis are typical and common. The neuroendocrine staining agents commonly used are CGA, SYN, CD56, and NSE, which we can see the next page. Various immunological markers. The next page. Yeah. Markers have varying degrees of sensitivity and specificity. CD56 possesses a high sensitivity but a low specificity, Consequently, it is preferable to use a combination of IHC markers as opposed to a single marker. For cervical NEC, SYN in conjunction with CD56 is far more dependable. And the INSM1 is a new immunological marker that is highly sensitive and specific. It can determine the tumor's tissue-specific origin as well as the starting point of the metastatic neuroendocrine tumor. And the pathway diagnosis. Yeah. Cervical NEC can be diagnosed through clinical symptoms, radiographic and nuclear imaging, and histopathology. The symptoms of cervical NEC include ectopic neuroendocrine secretion, such as Cushing syndrome, carcinoma syndrome, and hypoglycemia, SIDH, and hypercalcemia, as well as stomach discomfort. However, not all patients with cervical NEC will experience symptoms of ectopic neuroendocrine secretion. Instead, most patients may experience abnormal cervical smell, pelvic mass, irregular vaginal bleeding, or postmenopausal vaginal bleeding. As an invisible illness, cervical NEC may cause distant metastasis and systematic symptoms. Pelvic MRI is better than CT scans for detecting cervical NEC because it has higher soft tissue solution and can better measure tumor size and local infiltration. However, scar tissue and the remaining tumor tissue may have identical signal strengths, affecting MRI accuracy in cervical NEC recurrences. Thus, PET-CT and pelvic MRI complement clinical staging and recurrence. And the IHC is essential for cervical NEC diagnosis, which has been mentioned before. And differential diagnosis, we could differentiate this disease between the basal-like squamous cell carcinoma, undifferentiated carcinoma of the lower uterine segment, and the rhabdomyosarcoma, and the metastatic carcinoma. And the part 4, gene sequencing. The majority of targeted aerial sequences, WES and WGS, and facilitated by NGS technology. Eskander discovered that in a genomic analysis of HGNEC, the most common mutations were PICO3CA and MYC and TP53 and the PTEN. Gene genomic alteration of PIK3CA, TP53, and the PTEN AR1, DR1A, and the RB1 were associated with HPV. Interesting, it was found that GAS were more common in the HPV negative group than in the HPV positive group. The gene associated with DNA mismatch repair MMR system and then MYC TP53 KRAS cross and the PI3K AKT pathways are most likely to be altered. Next page, past 5, multimodality therapy. Yeah. Wishing for as for the surgery. And that's one, yeah. We also choose the radical hysterectomy, and regional lymphodenectomy, and the post-operative adjuvant therapy. This research we can find that out of 93 patients with stage 1 to 2 high-grade cervical NEC, and 88 underwent radical surgery as their initial treatment, while only 5 patients received radiation. In the surgical group, 37 patients received radical surgery and the pelvic lymphadenectomy in conjunction with postoperative chemotherapy, and 14 received surgery alone. 25 received surgery with adjuvant or neoadjuvant chemotherapy before the procedure. The HRN in the group exposed to direct radiation was 4.74. The surgical group's the OS rate was greater than that of the direct radiation group. And as for over 4 centimeters, we also choose chemoradiotherapy or neoadjuvant chemotherapy before surgery. And in a one doctor research, 2018 patients diagnosed with the high-grade NEC at pathological stages in the 1A, 2, 3C2 underwent primary surgery. The 5-year OS rate for patients in stage 1, 2, and 3 was 84.9%, 85.7%, and 60.9% respectively. And the KM survival curves indicated that there was no significant difference in OS and the PFS between patients who received post-operative chemoradiotherapy and those who only received chemotherapy. As for the chemotherapy, we also recommend using either EP or VAC. Studies have shown that EP is less toxic than VAC. In addition, the EP, TP, or TC regimen has been proven effective in specific clinical situation. The univariate analysis shown that patients who received chemotherapy with 4 or more circles had a better prognosis than those who received less than 4 circles. Combining immunotherapy with chemoradiation can have a synergistic effect with less comfort. And in the next page, the Fru moved found that the TPB region, which combines bevacizumab, paclitaxel, and cisplatin, outperformed non-TPB regimens in terms of PFS and OS. Radiotherapy is crucial for treating advanced stages of cervical NEC. And John discovered that the median several time for the surgery group was 44.6 months, while it was 80.9 months for the surgery plus radiotherapy group. However, radiotherapy should be used with caution when there is no metastasis present. As an addition of radiotherapy to surgery didn't show significant differences compared to surgery alone. The options for treating relapses of cervical NEC using traditional methods are limited. However, the use of immune checkpoint inhibitors provides hope for patients. And the last one, you could see gene discovery that out of 20 cervical NEC patients tested, and 70% were positive for PD-L1 and 75% were positive for PAP1. The high sensitivity or cervical NEC to PD-L1 and PAP1 suggests that inhibitors for PD-L1 and PAP1, as well as their combination, may provide a novel treatment strategy for cervical NEC. That's all. Thank you.
Selection criteria for HG patients in living donor liver transplantation in the past 20 years. Today, we have performed a total of over 2,400 liver transplants. 85% were living donor liver transplantation, and the 75% were from adult. Every year, about 100 case liver transplant were performed in our centers, and we routinely perform 2 to 3 cases per week. In recent years, hepatocellular carcinoma have become the most indication of the living donor liver transplantation in adult, over 50%. As we know, the Milan or UCS criteria are well-established selection criteria and have roughly recurrence rate about 75% in 5 years, but they are quite strict. For the tumor beyond criteria, many centers try to extend the criteria to treat more patients. As expected, the more the criteria extend, the higher recurrence rate. In addition, most criteria are based on the morphology of tumor size and the number, some of them combined with the tumor marker at the most. More importantly, most criteria are dichotomous, scarce the information of tumor biology, lack the index of the downstaging response, and just a static prediction, not dynamic information according to the availability of the clinical data. Since living donor liver transplantation takes the risk of donor, we believe we need to provide the best results of the recipient by reducing recurrence rate of hepatocellular carcinoma, at least better than the transplant. Are already available. We do not only develop multiple step selection criteria, we also optimize the timing of the living donor liver transplantation by pre-transplant management. Therefore, we need to dynamic models in each step of selection criteria to decide whether to proceed to the LDLT. Post-transplant can also use it to tailor immunosuppression protocol and give adjuvant therapy in the future to minimize the recurrence rate of hepatocellular carcinoma after LDLT. In the early stage, the 15 million criteria was mandatory for insurance coverage in our countries. What we did was to downstage the HCC by local regional therapy, which were initially beyond criteria to fit the Milan criteria. Then we can proceed to perform the LDLT. The 5-year survival rate can achieve the 90%. Survival for this kind of patients was also 90%. Since 2006, our insurance policy in our countries extend the criteria from Milan criteria to UCS criteria. We did the same study and found the survival was similar for those who presented initially beyond UCS criteria, were successfully downstage to fit UCS criteria. The 5-year survival was 90% and even a little better than those who initially fit UCS F criteria. We also found the AFP response to local regional therapy before transplant is an important predictor for HCC recurrence after liver transplant. So our initial algorithm for selecting patients with HCC to fit for liver transplant, we did not only include the UCS criteria, but also high FLP. We downstage tumor to fit the UCS criteria and the low FLP. Then we proceed to perform LDLT. Except the tumor morphology features, the tumor marks, tumor behavior, and the histology play an important role for recurrence. Most criteria, such as the UCSF criteria, is based on the morphology only. By image, in addition, tumor behavior should be taken for consideration, such as the ALP, PET scan, and the USFV, and the pathology. In these 3 patients with a small tumor size, less than 2 centimeters, and the normal AFP, we expect to be quite low recurrence rate before transplant. However, as all 3 patients develop tumor recurrence around 6 months after transplant, and overall survival was dismal due to the sarcomatoid type of the HCC. So our previous study also found that the 5-year survival is much less, only 50% in patients with a combined HCC and cholangiocarcinoma, compared to pure HCC group, about the 5-year, 90% survival. So the PET scan is quite important in our algorithms. We use the PET scan to select patients. If the CT scan show a typical image, we like to do the core biopsy before transplant. If the patient show unfavorable pathology, we just exclude the for transplant to reduce the HCC recurrence. So, but before transplant, it's quite difficult to obtain the pathology. And so far, we didn't have the non-invasive pre-transplant surrogate to predict the tumor behavior before transplant. So in this study, from our previous study, we showed that if pre-transplant PET scan was negative, the recurrence is only 9% after liver transplantation. But if the PET scan positive, the recurrence rate about 1/3 over the 30%. You PET scan positive and with a high SUV, the recurrence rate can up to the 2/3 over the 62%. So from our previous study, about 500 cases of HCC after liver transplant, we found the most important factor is the pathology, showing the microvascular invasion and the unfavorable histology, which were the most important predictor to predict HCC recurrence after liver transplant. So we look for the study the relationship of the PET scan and the microvascular invasion. We found the PET scan positive is closely correlated with the microvascular invasion of HCC in post-transplant explanted livers. The specificity is 91%, and the accuracy rate about 75%. So how about a relationship between PET scan and the unfavorable histology? The PET scan positive also highly correlated with the unfavorable histology, about specifically about 87%, and the accuracy rate is about 85%. So PET scan play a pivotal role in our selection criteria. You PET scan positive, we try to get the pathology before transplant to exclude the unfavorable pathology for liver transplant. You PET scan negative, we direct the procedure to the LOD, LT. We also found that the recurrence rate is quite low. You explain the liver showing the complete tumor necrosis, about 1.2%, compared to the 12.6% in those with a viable tumor in explained livers. As such, we try to give additional local regional therapy for the viable tumors, attempt to achieve the complete tumor necrosis if possible, and try to reduce the HCC recurrence rate as possible. So taken together, we have developed a dynamic prediction models of the availability of the clinical information. So pre-transplant, we calculate the recurrence rate to decide whether to proceed to LD, LT. So this 30 years old male patient HPV carrier with TRIPU score 5, 10 centimeter with high AFP over 10,000. We expect the recurrence rate about 32% immediate after liver transplant. So we did the test for this kind of patients, and unfortunately, after the local regional sample, the AFP dropped to the normal, and before transplant, the PET scan is negative. So we recalculated the recurrence rate about 30%. So that we advised him to do the liver transplant. So after transplant, the pathology showing the microvascular invasion is negative, and the tumor with the 100% necrosis. So the recurrence rate about 5%. So we did not, we don't need to give any additional treatment for this kind of patients. In contrast, for this example, a 61-year-old male was a patient HPV with a TRIPU score 8. The tumor was single and only 3.5 centimeter with normal AFP. The pre-transplant showing the early enhanced and the early washout typical image. The recurrence rate about 50% by our formula. Then we perform the test first, the attempt to reduce the recurrence. But before transplant, the PET scan showing the positive, and the SUV was 3. The estimated recurrence rate was 35% by the PET scan positive findings. Unfortunately, after transplant, the final pathology showing a cordial carcinoma, which was a Desmoid results after liver transplantation, and the recurrence rate was quite high. Unfortunately, this patient died of the tumor recurrence 2 years after liver transplantation. So multiple step dynamic prediction models in our center, we can decide whether to proceed to the LD before transplant. And after transplant, we can take the immunosuppression and try to give the adjuvant therapy to minimize the recurrence of the HCC. So recently, we have been trying to reduce recurrence in high-risk patients, for example, PET positive patients, try to, by using a post-transplant adjuvant therapy to increasing the survival rate by target therapy. So we revised our algorithm. If the patient with a high-risk patient With PET-scan positive or unfavorable tumors, we try to give the radio downstage first, either by E319 or proton therapy. And the post-transplant, we can give the adjuvant therapy by combined treatment. I try to minimize the recurrence of HCC. For example, in these patients, this is the 59 years females with multiple HCC, and especially the one big tumor over 80% in the right lobe. So with the so both these patient is not suitable for E319 because only small randomly randomly forced to get out of big tumors. The tumor in the stage 3B, which means the right portal. After the right lobotomy, the small tumor we eat is all. So after even we followed by liver transplantation, so the tumor showing the thrombosis, the patient by this approach, the patient get a 2 years disease-free survival so far, and we know the transplantation. And that is a potential for the infiltrative HCC, with the right and the left portal, and we give the puncture tumor shrinkage, and the portal vein thrombosis can shrinkage or disappear. After that, followed by the liver transplantation and the expandable sugar proton therapy, and the patient. So this the similar cases, the thrombosis, and we give the proton therapy disappear. We follow by the transplantation, and by this way, opportunity of long-term survival. So far, the study is still ongoing. What we found is quite promising data for high risk patients before adjuvant therapy and the radio downstage. The 5-year survival is much lower, and we try to increase the survival to similar to the low risk patients. And the overall survival is quite similar results. So for the local advanced high-risk HCC, we not to the patient to do the liver transplant directly. We needed to advise the patient to have the successful pre-transplant radio downstage, either by proton or E319. After successful downstage, we can to the living donor liver transplantation and followed by the adjuvant therapy by target therapy. By this way, we living donor liver transplantation, we provide the long-term curative survival for this kind of the local advanced HCC patients. Thank you for your listening.
Doctor?
Yeah.
Your voice is lagging, doctor.
Can you hear me now?
Yes, we can hear you perfectly.
Thank you so much for inviting me here to share my thoughts. I would like to convey my gratitude towards the organizing committee of this conference and gave me this opportunity to share my thoughts in front of the eminent speakers in this field. So I'm going to share my thought on the title called Pain Beyond Cancer, Psychosocial Support for Patients Who Lost Their Daughters During Their Treatment Trajectory through the case series. Let me introduce myself. I'm a clinical psychologist from India. I'm registered with Rehabilitation Council of India. I was working in Command Hospital before, and for last 6 months, I'm working in Rocket Health, is another organization. So let's. In this presentation, I'm going to cover the basic introduction that understanding the cancer and its treatment process, role of psychosocial intervention, pain beyond cancer with the case series, the brief chapter, reference, and the conclusion. Now coming to the first section is understanding the cancer. What is the basic scientific definition of cancer by WHO or any other research area? That cancer can any part of the body can be affected by the cancer. It's an abnormal cell growth, and that can invade adjoining parts of the body and spread to other organs. So these are the basic understanding, the scientific understanding of cancer. But what is the definition of cancer to a patient? So when a patient gets the diagnosis, when the patient receives the diagnosis from the expert, the first thought they just to have that how much time I have, because they feel that it is a deadly disease. To some extent, it is true that it is a deadly disease, but at the same time, a number of researches are going on to reduce the mortality rate and to increase the quality of the treatment process. So it is not truly the deadly disease now, but there is a lag between the awareness. The spiritual doubt. Did I wrong somewhere? When did I do something wrong in my life, in my daily functionality to take care of my family, to take care of my child and other areas? The spiritual doubt is there. The pause button in current lives. For example, my life was going well, neither that great, neither that bad. But after getting the diagnosis, someone has come and clicked the pause button in my current life. If I be able to fulfill my dreams after getting the diagnosis. And the very common thought is, why me? And the relationship, whether I be able to maintain the relationship with others the way I used to maintain before. So this is the basic understanding of the cancer to a patient. Now coming to the understanding of the treatment process. A healthcare system can offer the chemotherapy, surgery, radiation therapy, hormone therapy, plasma cell treatment, and other treatment process as per the need of the patient and the condition of the treatment, condition of the illness. But how patient perceive the process? The hair loss, alopecia, it is often associated with the cancer treatment. No matter what treatment the patient is going to take, the stigma, the awareness of hair loss is associated with everything, every part of the treatment, leading to social stigma, leading to social self-image, because hair is an important part of aesthetic sense, a part of identity, part of beauty. So without hair, the person will lose the part of her identity. So that leads to the self-image issue, and that may also lead to relationship issues as well. Along with the same, the financial burden. As we know, the treatment process, the treatment cost is very high, and it is not that affordable for everyone in the world. The financial burden is there. At the same time, the availability and the accessibility of the healthcare, because due to the side effects of the treatment process, the patients have to have a regular contact with the healthcare system. But what we have seen in our practice that many of the patients lack that availability because of the distance, because they stay far away from the hospital. So that is another concern. And duration of the treatment is again. So financial burden, accessibility and availability of the healthcare and duration of the treatment are interrelated with each other. And that affects the changes in lifestyle. The restriction could be due to the treatment process, the side effects, the financial area. And now comes the role of psychosocial intervention to bridge the gap between the healthcare system and the patient's mental health. If we do not address their concerns, their needs, then we will not be able to we will not be able to convince them to start the therapeutic journey. Even if they start their therapy, I mean the treatment process, they may drop out after some time. So bridging the gap and addressing their concern is very important. To explore the support system is very important because in every crisis situation, we search for the support system. The support system can be the patient herself or himself, but exploring that and communicating that to the patient is also important. To enhance the adherence level is a part of that, reaching the gap. And to continue need-based intervention from pre-diagnostic phase to post-treatment phase. So why I'm using the word need-based intervention? Every patient gets the distress after getting the diagnosis. But that doesn't mean that distress needs to be addressed by the psychosocial intervention. The patient, assuming that the patient has no coping ability, would be dropped. So that is why the need is very important here to understand whether the person is in need to cope with the situation or not. Now, moving to the main focus of my presentation is pain beyond cancer, the case study. How it feels when we confront with a new major life event while coping with the another one. I'm going to show two case studies here, and along with the clinical interview, I have used this tool, that is NCCN distress thermometer. This tool is developed by National Comprehensive Cancer Network. This is also known as NCCN distress thermometer and problem list. So it has two parts. It measures the distress level as well as the problem areas. It measures distress on a 0 to 10 scale. Higher score means greater distress. And the problem list helps us to understand the areas that are causing distress. Now coming to the first case, Mrs. Devi, the name has changed. She is 38 years old, female woman, hailing from rural area of India. And she's married with 3 kids, 2 sons and 1 daughter. As her husband is army personnel, so she lives with her, and her elder son is also an army personnel. So she stays with her younger son and her daughter. We have started noting the distress score from February 2022. And she has been diagnosed with breast cancer before. And after the post-treatment, after the treatment for the breast cancer, she was maintaining well for a few years. But lately, from December 2021, she started experiencing back pain, lower back pain, severe pain in lower portion of his body, along with difficulty in walking and standing straight. So for this concern, she visited the hospital and then diagnosed with metastatic skeletal lesion in January. Upon exploring, it has been revealed that her family was a main support system, and the daughter was her main primary caregiver, and she was 19 years old then. And her main problem area was difficulty in walking and standing straight. And upon assessing, we have explored that her distress score was 6. And that time, the aim of the psychotherapy was to reduce the distress level and to increase the adherence level to the treatment process. So with psychotherapy, supportive therapy, general guidance regarding the treatment process and the prognosis, she started coping well until November. 2020 till the point she received the information regarding her child's health. Now coming to the next case, Mrs. Das, again the name has changed. She's 48 years old, female woman, hailing from urban area. She has been separated from her husband since her child's 3 years of age. So she all alone reared her daughter up. And again, her husband was a family, husband was in army. So for both the cases, they used to get the treatment in free of cost. And she has been diagnosed with CA breast, and the time of diagnosis was April 2022. Upon exploring the support system herself, daughter and granddaughter, and her primary caregiver was herself only and neighbor at times. And her entire life has been centered around her daughter and her brand. And the main problem areas was diagnosis and the treatment process is a very common problem areas for every patient diagnosed with the cancer. And initially, upon exploring the need assessment, initially her distress score was 5, but the coping mechanism was healthy. She was adaptively coping with the situation and was having a positive outlook for the same. So no structured psychotherapy was needed that time. And she was maintaining well till October. During that period, from April to October, she was not in her in any active treatment process, but before she was doing some necessary processes for the treatment. Now we are moving to the instability of support system and increased distress score. For Mrs. Devi, for both the cases, till the point they heard their child's health is deteriorating and health concern. That point, both of their distress level shot up to 9 from the low level, from 3 to for case 1 and from 4 to case 2. Let's start with Mrs. Devi. Till November, she was maintaining better in terms of her mental health. In December, her daughter admitted in hospital with acute headache, had fever, and later she has been diagnosed with brain meningitis. That time, it was very difficult for her to digest the fact, and her main problem was problem areas were daughter's health, instability of support system. Who is going to take care of her? Because her daughter was the primary caregiver of her. And who is going to accompany her to continue her treatment process in the cancer field? Because she used to stay 80 kilometers away from the hospital. So her daughter also used to accompany her to the hospital to take the treatment. So these were the main problem areas she was suffering from that time. And with time, with supportive counseling, psychotherapeutic intervention, she was trying to deal with the situation in a better way. And for till February, till she lost her child. And in February, after December, she used to come to hospital with her neighbor accompanying her. But in February, for the first time, she came alone in the hospital to take her treatment. At the same time, her condition was gradually improving though. But she was struggled a lot because her daughter's health was not at all good. And she lost her daughter in February. Coming to case 2, Mrs. Das. Up till October, she was maintaining well, coping adaptively with the situation. In the November 2022, when she went for her breast surgery, the very next day, her daughter admitted in the hospital with the heart issues and for the transplantation of implantation of ICT machine. And that time, her problem areas was focusing on her daughter's health, instability of support system, and the financial issue. Instability of support system because her entire life is surrounded, centered around her daughter. So the instability of support system and the financial burden was concerning her and increased that distress level to 9. However, she was she was trying to cope with the situation in a better way. And for both the cases, the aim of the psychotherapy was not to reduce the distress score, but to continue the functionality of their life optimally so that they can continue their treatment process and they can do the needful for their children as well. So for case 2, Mrs. Das was trying her best to save her child because for her child, the only option was heart transplantation. She tried her best, but unfortunately, she couldn't. On June 23rd, her child passed away because lately she was not capable. She was not able to take that transplantation. And then the grief chapter set in. When they came back after their loss, the grief assessment done through the clinical interview, focusing on the cognitive symptoms, physical symptoms, and the emotional symptoms. And we have found that increased sadness and prying behavior with negative thoughts is very common. And increased disturbance in sleep and appetite. Why I'm saying increased? Because the sleep and appetite was already being disturbed because they were undergoing the therapy, treatment process as well, and due to the stress of their daughter. And it is very important point we have explored that they were very reluctant to continue their treatment process. That they're cancer with the feeling of guilt, with the thought that they should stop their treatment because they have not given better treatment to their child. So they couldn't save their child. So they should stop their treatment. Leading to the psychotherapy that time the focus of the psychotherapy was to process the grief in a better way and living with acceptance and adherence to the treatment process. With continuous grief counseling after 2-3 months of the therapeutic journey and their treatment process, they somehow managed to continue their treatment process. Taking the treatment for the cancer. At the same time, they started realizing that in their short period, for their child, though they have lived for a very short period of time, but still they have lived their life the way they wanted. For case 1, as she belongs from a very rural and village area in India, in their culture, in their society, education gets less priority in comparison to marriage. But her child, Mrs. Devi's child, she wanted to pursue with higher study, and she was preparing for that. And her mother, Mrs. Devi, was allowing that. She was very supportive to that. And in case of case 2, she's from urban area, and here the education gets more priority than marriage in younger age. But her daughter wanted to get married at her early age and wanted to have a kid. And that time, Mrs. Das allowed her for the same. So for both the cases, both the mothers started realizing the fact that as a mother, they have done from their end the way, and that is why they could lead their life in a better way. So that gives some positivity and hope to live further and to continue their treatment process. So coming to the end, the conclusion, I would like to conclude my presentation with the thought that no matter how dark the night is, the sun will always rise with its ray of hope. So the pain is inevitable. We all experience pain. We have experienced it, we are experiencing it, and we will be experiencing it in future as well. But the suffering can be dealt with proper intervention in a better way. And the importance of psychotherapy in oncocare is very crucial, as it not only focuses on the illness, rather on its trajectory. thank you so much for your patience and listening to me. And if you have any question, you can tell me now, or you can reach out to me through my email ID. Thank you.
Thank you. So my name is Dr. Ashwin. I'm a general surgeon from India. I was a senior resident in Department of General Surgery in Surgery Hospital, tertiary level hospital in New Delhi. So this was actually my thesis topic as well. This was a new way of assessing axilla in patients with breast cancer. So patients with breast cancer, we know, have lymph nodes that have spread from the breast to axilla. Now, the problem with the axillary lymph nodes are that the axillary lymph nodes have both drainage from the breast as well as from the arm. So, an invasive approach to axilla will lead to more lymph nodes being removed from the arm lymphatics, leading to lymphedema. That is the most dreaded complication a surgeon can face as far as axillary dissection is. So we have something on sentinel lymph node, which is the first lymph node that is draining the lymphatic base of the breast or any of the primary organ. And sentinel lymph node biopsy is a feasible alternative to lymph node clearance. Rather than removing all the lymph nodes from the lymphatic basin of a primary organ, what we can do is target the first lymph node, which is draining the particular organ, and test for it. Remove it and test it, whether the node is involved or not. And hence, we can decide whether to continue to do the further dissection in the particular lymph node basin. And this will help in avoiding the morbidities associated with ALND, which is the axillary lymph node dissection. Now, the objectives of my study were to assess the sentinel lymph node dissection of the area with the help of methylene blue dye, just the methylene blue dye, and assess the sensitivity, specificity, positivity rate, and accuracy. What I also did was to assess the axilla with the perspective of the arm lymphatics, the lymph nodes that are draining the arm, with the help of a reverse axillary mapping. Because we are giving dye in the arm, it becomes reverse. Now, I included patients who were undergoing both modified radical mastectomy as well as breast conservation surgery. And a non-allergy to the dyes were obviously a contraindication, and so were the patients being pregnant at the time. Sentinel lymph node biopsy was done with the help of a methylene blue dye, which was injected. An amount of 1 ml was decided, and as compared to the previous studies which were utilizing methylene blue dye, and the dye was injected in the periareolar region. And the nodes which were blue were identified and isolated and were sent for frozen section. And in all the patients, we did an axillary lymph node dissection regardless of whether the sentinel lymph node was positive or not. This was to do a comparative study. So the final histology of the axillary nodes were done in all the patients, and we have compared the results of the sentinel lymph node with it. So as you can see in the figure, we are giving the dye periareolarly around the nipple areolar complex. And after that, we will do the normal dissection and we'll identify the axillary lymph node. As you can see, the node has attained a blue color, which is how we identify sentinel lymph node with the help of a dye. An alternative to this and a better technique to this would be using a radiocolor dye, and we can use a gamma camera to detect it as well. So axillary reverse mapping is the second part of my study, in which I would inject 1 ml of the fluorescent dye, sodium fluorescent dye, in the arm. And a distance of 10 centimeter was taken from the acromion process as the landmark on where to give the dye. Upon giving the dye, we will massage the area, and after the axillary dissection is done, we will illuminate the area, the axillary dissection area, with the help of a fluorescent lamp. The fluorescent lamp, and then the nodes which were appearing fluorescent were removed and sent in a different container, and were again compared with the gold standard, which is the axillary nodes. So as you can see in this picture, this is the axillary. On the left, we have the axillary lymph node, which is draining the arm, which had taken up the fluorescent dye, which were visible as a greenish node in a blue lamp. And we can see that the most of the nodes which were eliminated are present in the axilla were superior as compared to the nodes which were not taking up the dye. So as you can see in the white label, this is the uppermost intercostal brachial nerve. So the intercostal brachial nerve was used by me as a landmark to differentiate on the nodes which were taking up the dye and which were not taking up the dye. So this can help in redefining the boundaries of the existing axillary lymph node dissection. So at the end of the study, which had a mere sample size of 30, we were happy to report no reaction to methylene blue or fluorescein dye, and we were able to identify nodes in all the patients, both sentinel lymphnode and axillary reverse mapping nodes in all the patients. And we are also happy to report that none of the patients had any malignancy from the nodes which are taking up the fluorescent dye, which are injected in the arm. And also, supramost intercostal brachial nerve can be used as a new landmark, because in our patients, the nodes which were taking up the dye were exclusively present above the intercostal brachial nerve in 83% of the patient. Now we need more studies with more higher sample size to have better results and outcome to see whether this is a plausible thing in the future. So at the end of my study, I was able to conclude that we were able to use methylene blue dye alone and have good results as far as sentinel lymph node dissection is concerned, and also a malignancy-free nodes were sampled in the patients who are undergoing axial reverse mapping. So a combination of this sentinel lymph node dissection and axial reverse mapping can help us in guiding to do axial lymph node dissection, which to begin with was very invasive and had complications like lymphedema. So this will help us in improving ourselves as surgeons and as medical personnel to improve the care that we are providing to the patients. Thank you.
Hi, good afternoon, everybody. My name is Dr. Harsha Agarwal. I am head of Psychology Department, Rajiv Gandhi Cancer Institute and Research Center, Delhi, India. So today I am going to talk about effects of cyberchondriasis on cancer patients undergoing medical treatment, understanding the impact and mitigation strategies. So first, let's discuss about what is cyberchondriasis. So basically, cyberchondriasis is a kind of a health anxiety. The behavior of individuals who compulsively search the internet for information about their health concerns, often leading to increased anxiety and distress. In short, nowadays, whatever we do is, as a human being, whatever we are feeling, whatever we are facing, the first thing which we go for is search it on Google. Everything we search it on Google and try to anticipate whatever we find out on Google that we are having it. So the key characteristics for cyberchondriasis are: one, excessive online searching. So one search leads to another search, which leads to another, and a list of searches, which escalates any days our anxiety. We are not sure about whatever the information we are receiving is right or not. So a kind of a misinformation is being received. Then there is no diagnosis which has been given by a doctor, but we self-diagnose ourselves. Then certainly there is going to be disruption of medical treatment. Why? Because as we have ourselves diagnosed ourselves and we have no base for that, so we are not even ready to go for the medical treatment for the same. Then we go for the compulsive behavior. Now, what is compulsive behavior? That because of the online searches, because of information which I have received, because of my own made diagnosis for myself, for my symptoms, I have a behavior that whatever is been told to me, even by a medical professional, whether it is right or not. So I am judging. So that leads to a compulsive thing. The cyberchondriasis can negatively impact individuals' mental and physical health, particularly if it leads to increased stress, avoidance, unnecessary medical treatment, or necessary medical treatment, delaying in the medical treatment, over-reliance on unverified information. Because I don't know, as a normal layman, whatever I'm searching on Google, whether it is applicable on me or not. Healthcare providers, doctors can actually play a crucial role in mitigating these effects. So in my current presentation, we are going to study about the same. So first thing, why cancer patients turn to the internet? First is seeking insurance and information. Because I am a layman, I would like to know more about whatever I'm going through, what doctors are going to tell me, and whatever they're telling me, how or what is the impact it is going to have on me. So the desire of information is really high. I have a desire to control and empower everything. I need to have that feeling of that I know everything even before I'm going to meet a doctor. Then lack of immediate medical access. I'm not saying that we do not have people, but I, as a person, first based on my researches, then I try to find who is going to be the right person, and I'm not going to meet the doctor first. Maybe if I'll go to one doctor or a physician, let's say, I can meet up different doctors.
Sorry for the interruption. Hello,
Yes.
Dr. Archa. Your slides are not moving.
My slides are not moving, but in my PC it is moving. Okay, let me just see. I don't know what is the concern. Let me see. It is being moved in my PC. I don't know how it is not moving. Let me just stop it from here and do it from a tab.
Can we share it from your side?
Yeah, sure, please.
Yeah.
You can.
Please wait.
Can we move to the third slide? Right. Thank you. So the lack of immediate medical access I was talking about. It is not that we do not have appropriate person around us, but we, because of the information which we have received, we do not try to find out the right person. I'm sorry for the disruption. Right. Then complexity. I guess. Right. Then the complexity of information we have received. It also depends. It also makes it unnecessary and uncertainty of the cancer. Why we are searching for the complex information? Because as a layman, I want to know about the exact thing. I don't know whether it is tumor, whether it is benign, it is malignant, or whatever the consequences can be. Then there is an influence of personal stories and experiences online. So whatever I am searching online, I am going to receive some kind of personal experience and stories of survivors, of warriors, of people who are already suffering. Now I relate to that as a person, as a human, as a patient who's going to go through everything. But as an individual, I do not understand that their journey and my journey can be completely different. So, but I get influenced by whatever the people's story I receive on internet. Then there is a mistrust and dissatisfaction with healthcare providers, because there is a very known fact which is very prevalent in society these days, and which I also come across as a psychologist from my patients. They tell me that we don't know whether doctor is going to tell us about us, whether they are not focusing more on money or whether they are focusing more on us. So I would like to know everything pre-hand. I want to have all the information about whatever test is going to be told to me, whatever the impact of those tests can be, what the results are going to tell me. Then based on those results, what doctors are going to tell me about the same. Then recommendations from others, which is very, very, very important. Recommendations here are not from the verified and qualified doctors, but people we have at our own house, people in our own vicinity, that is our neighbors, then our relatives and friends. They recommend a lot of things. So based on that, again we start on seeking the reassurance and information. Again, this circle goes on viciously and it's unstoppable. Next, please. Can we get on to next slide, please? Right. So, as I've told you about, that this cyberchondriasis increases the anxiety and stress. Now, if I have as a person, my anxiety and stress are high, then how is it going to impact? One, why I have anxiety and stress is exposure to worst case scenarios. Because online, I do not search for the mediocre thing. Whatever I'm getting are two extremes. Either I'm getting very good scenarios or I'm worse scenarios. As a human, mind focuses more on the negative things. So I see what the worst case scenario can be. How much prevalent that information, whatever negative information I'm getting, is relevant. I focus more on that which relates to my mental health and which deteriorates it also, because now I start having negative effect about that. For example, cancer. Cancer is equals to death. Why? Because whatever the worst case scenarios I've been hearing about, whatever I'm reading about or I'm facing or I'm seeing online, they are more about that what are the negative effects of treatments can be. I do not see the positive side of it also. So, for example, if the scenario is about 80% we cannot survive and 20% is the survival rate. So now the patient is not seeing that there is a 20% positive chances also. They only see the 80%. This is the worst case scenario which I'm telling you. Then there is a alarmist and misleading information. Whatever information they are getting on internet, we don't know whether it is applicable on you or not, what your scenario is and what the scenario of that patient was. But sensationalization or sensationalism is there, that such patient has been through this, got this the same diagnosis, but we don't know at what stage, what physical condition of the patient was, at what time they started their treatment. But I very blindly focus on the same thing, that the patient also had the same diagnosis, I have the same diagnosis, the patient could not survive, so I will also not. Which distorts the perception of a person about the disease, about the treatment they may receive, which may result into good side also. It also heightened the mental health challenges also. As my perception is distorted, I will have good amount of anxiety in me. I will be focusing more on everything which is negative. What negative doctors are telling, I will not focus on what positive doctor is going to tell me. I will only focus on negatives. I will only focus on what bad doctor is saying. I will only focus on what negative effects I am going to have. For example, when doctors are going to tell about the negative or side effects of chemotherapy and how they can be managed, but patient is only going to focus on what side effects the patient is going to have. And as a stress response, what happens is when they get onto chemotherapy, they just focus on now the chemotherapy is starting. So either before starting of chemotherapy, they have anticipated nausea and vomiting. When they start the chemotherapy, they get on with the chemotherapy. even before any other thing, they will start having nausea, vomiting, headaches, body aches, psychosomatic symptoms. They'll start having those symptoms. As a stress response, it happens, which consequently impacts the daily life of the person. They will have sleep disturbance, they will have difficulty in concentrating on any other stuff than their disease and their treatment, which also leads them to withdraw from the society because of the negative effect they are having in themselves and about the disease. They feel that now if they are going to be in society, if they are going to sit with their friends, or they are going to meet their friends, or if they allow people to come and meet them, they're only going to talk about disease and will show sympathy. Thus they withdraw themselves. Next please. The misinformation and misinterpretation about the internet searches. Now, first, encountering unverified or false information. The first thing which a person gets on internet is information. Now, I as a person do not know whether this quality of information, whatever I'm getting, is correct or not, applicable or not, whether the quality of information which I'm getting is variable or not, because whatever information we are getting on the internet, they are done or they are based on few researches done on a set of population sample. Whether that sample is applicable on my population or not, as a layman I don't know. So the proliferation of myths are also there in these information which are unverified, which leads to difficulty in distinguishing reliable sources or not. So I, as a person, as a profession, we may know what websites I should search for the right kind of information. But as a patient, as a layman, they don't know. They just put in their few symptoms. They just put in chemotherapy and they'll get a list of 40, 50. Am I visible and audible?
Yes, doctor, you are.
Yeah. Whatever I'm searching on online, not complex medical terminology which I am going to search, or which on searches I get in as a result. I go on to search on that again. If I do not understand that, I click on another link which describes that. But in those clicks, I don't know whether I am leading to a verified sources or not. So the trust issues are also there. Then that also leads to confusion about their condition and treatment. Because now from one source to another, to another, to another, when I'm leading a long pathway, I don't know whether I have uh, drove myself on the right path or not. So the conflicting information which a patient is receiving at times becomes overwhelming for them to understand, to sync the information in, to get the right path, which also leads to doubt on medical professionals. Now, the patient with this start doubting the medical advice which they are getting. They start getting ineffective. They start doubting the effectiveness of the treatment which they are getting as well. Next, so this is the kind of interpretation which they get on encountering the information which they get on putting on internet, the information which they are receiving, whether that is from reliable or unreliable source, I'm not sure about it. The confusion which that information has created in me makes a person doubt on the treatment and delay the treatment as well. Next slide, please. which very consequently impact the treatment adherence, because the doubting or medical advice conflicting on the based on the conflicts which a patient has or received on the online information, what doctors are saying. There's a erosion of trust in a patient, that whatever I search that says this A, and whatever my doctor is saying is B. Now what is right, A or B? For that, what they do is they go for further references. They delay their further treatment. There is a reluctance in them on the prescribed treatment by the doctor, because they have a lot of fears in them, fears of side effects of treatment, fear of getting the wrong treatment, fear of getting anything as a consequence of the treatment. Thus, they prefer more on getting one verified and assurance and reassurances than on going through the treatment, which actually gets into delay of the treatment and also leads to some potential effects or side effects, I would say. But patient is not uh, at times ready to understand that because of cyberchondriasis and receiving informations which are not verified can actually impact the treatment. But rather a patient actually tries to prefer whatever they have received from unverified information about the treatment, they rather stick to them. Then there's a potential worsening of health outcomes due to their non-adherence. Because of the delayed treatment, there is a delayed recovery as well. At times it becomes, I receive patients on a day-to-day basis that because of the cyberchondriasis, they have delayed their treatment, which at times makes it a palliative treatment than on a curative treatment. That now, because of so much delay in the treatment, in seeking treatment, the doctors do not have a curative intent, but rather they can focus on palliative, that is controlling intent. Next slide, please. Now, there is also a strained doctor-patient relationship because of cyberchondriasis. Why so? Because of frequent challenges to medical advice, whatever the patient has received or attendant has received on internet, they try to keep questioning the expertise of the doctor, putting the relationship they have into conflicting scenarios. There is erosion of trust because of information they have received. Because of the information they have received, there is a doubt in professional judgment. Now they see patient or attendant feel that whatever they are going to get, is it right up to the professional thing? Whether they are not having any other benefit out of it. So they try to see things more. Again asking the same questions in different manners, again trying to take the assurance and reassurances for the whatever information they have received, and whatever doctors are going to tell them are right or not, which one to go for and which one not to go for. Then complications in managing the treatment process, which actually leads to increased consultation time. At times, it is not possible for a consultant, for a medical doctor, to provide them with that enough time, because they have told you the information up to whatever they have. They do tell about what the disease is. If we are going to start the treatment now, then what is going to happen? If we do not start with treatment, then what kind of treatments we have, what all lines of treatment we have, A, B, C, D, let's say. If we start with A, then what, B, then what, C, then what, and D, then what. But because patient or attendant has already got the information online, now they seek more information. Rather, they're not focusing on the right kind of information which a verified medical professional is giving them, which ultimately strains the relationship of a doctor and a patient. Next slide, please. Now, about psychological distress, this cyberchondriasis causes. So there are 4 points in this. One, there is an increased chronic stress and worry among the patients and attendants. There's a detrimental effect on emotional well-being of theirs, which actually impacts the quality of life of them, and also development of compulsive health information searching. Now, when there is an increased chronic stress and worry, the patient and attendants are always into anxiety. And there is an anticipatory anxiety also. One is anxiety that I am doing this is going to happen next. Anticipatory is, if I'll do this, then what will happen? If I don't do it, then what will happen? For example, with chemotherapy, when the patients are on, let's say, high dose of chemotherapy, they understand only that with high dose chemotherapy, they're going to have a negative effects, the side effects such as nausea and vomiting, for example, frequent nausea and vomitings or diarrhea. But for which to maintain that, they do not focus on having healthy diet. Rather, they just focus on, because now the medicine is on, so they will have anticipatory or they will have nausea and vomiting. They do not focus on the managing part, which doctors also tell them that you can manage it, but they only focus on the negative, which actually leads them to have more of depression for themselves. At times they feel that whenever the medicine will be on, they will be sick, they will be bedridden, they will not be able to do this or that, they will be only on the bed and dependent, which makes them feel depressed about themselves, which do not make them comfortable with the hospital settings as well, and which makes them isolate themselves. They start suppressing themselves. They don't ask frequent questions. As psychologist and psycho-oncologist, I have been scratching these things out of them to find out what is actually making them isolate themselves, why they are suppressing, why they're not talking, why they are not making self-efforts to improve themselves also. So in order to improve the quality of life, the impact which they are getting are they reduce enjoyment and they have impaired functioning are the major two things which I came across with. They say that because we are dependent, so we can't do this or we can't do that. I can't enjoy. Now when people are laughing around me, I feel they're laughing on me instead of they're laughing for me. Because I do not have proper functioning, my functioning is impaired, so I can't be involved into things. So we push them to do it. We push them, we motivate them, we orient them to the right thing. As a result of impact on quality of life, there is a development of compulsive health information searching. Now, one search was, if I will start my treatment, then what? Now I also add on to that, I started my treatment and now I'm facing this. Now what? So this becomes a behavioral addiction, which is unstoppable. I keep on searching Google or internet for n number of things, and I'm not focusing on the positives which they are showing. I am only focusing on negative because I am getting negative. I am getting negative side effects, so I focus on negative only. Rather, I do not focus why those side effects are coming up in me. Next slide, please. Now, overall overuse of healthcare resources with cyberchondriasis, this is very, very prevalent. One is unnecessary consultation, second opinions, because I do not feel satisfaction with the information I'm receiving from one. Just like I'm doing it on internet, I do it with the physical doctor visits as well. At times when I am having diarrhea, which is a side effect of a chemotherapy, which can be a side effect of chemotherapy. But I would rather, focusing that it is a general side effect, I would rather try to speak to a specialist of, let's say, GI, in order to see whether this is normal or not. So I have increase in free doctor visits, specialist referrals. These are redundant or invasive diagnostic procedures which I may go through. Excessive testings, even if a small thing is happening, get me tested. I do not wait as a patient or attendant, or I do not trust my treating team more. Rather, I keep on getting myself tested. which certainly increases the burden on healthcare system as well. Because of increased testing for, let's say, something which should not be tested for. Then there is increase in waiting time also for them. It is not only for one person. Maybe because of them, there is increase in waiting time for a person who is getting tested for first time also. Because we have limited resources and we have to allocate them only. Then there's a potential of invasive procedure. At times, let's say that if I've just gone post chemotherapy, if I'm having abdominal aches or some aches, I would rather ask my doctors to get it tested, maybe through endoscopy or through, let's say, any other further testing, that you do first this, then only go through anything. There is a risk also, and there are costs involved as well. But because of the information I've received on internet, I would like to get things done first. Next slide, please. There is a delay in medical treatment attention as well. Because of the Google or internet searches, what happens is a misinterpretation of symptom severity. I either underestimate my severity or I overestimate. When I overestimate, the earlier slide matters, that because of overestimation of things, I am going for multiple doctor's visits, I'm going for specialist visits, or I'm asking for, let's say, invasive procedures as well to get done. But when I go for underestimating things, I get false reassurance for myself that nahin, this is fine and everything will be better. This is normal. Then there is delay in seeking appropriate care. At times, the information which I am not relying on, or I rely on my own self-diagnosis, what happens is I am not seeking the right kind of care. So what we do as a psychologist in such cases is, whenever my patient is getting any, even a itching, let's say, or mild ache, we certainly tell them and motivate them to tell each and every symptom to their family members and to the healthcare providers, so that we can let them know what is to be concerned for and what is not. We will let them know that this is going to happen with the treatment you are on and this is not to be happening. So they can receive the right kind of treatment at the right time, instead of searching on internet about the symptoms which they are getting. Tell us so that they can get the treatment. The potential worsen healthcare outcomes due to delay because of cyberchondriasis are: one, avoidance behavior, and second is procrastination. As I procrastinate about my own symptoms and I generalize them, it will happen. It has to happen. Doctors have told me that. I have gone through the internet. This happens with everybody. So I try to avoid myself, and I try to avoid the hospital setting. Thus I delay the seeking of appropriate care. Next slide, please. We focus on more of negative outcomes. With the information we have received online, my emphasis are on rare and severe scenarios, which is obviously leads to availability biases and sensational content. It is based on that. Now, when I'm focusing more on rare and severe scenarios, it happens that I may not be that case, but I generalize because I'm not having A, B, C, D, E, so my things are normal. These deserve no care, or these are fine, has to happen, will be fine. Or what happens is, either two things which are happening to me, I only consider them into the serious cases, the rarest one. I focus on, no, this shouldn't be happening, this is happening to me, so this is really a serious one. I go for an overestimation of the things and emphasis more on this as a rare thing, which increase my feeling of hopelessness and despair as well. I get into negativity bias. I focus on only negative things, that this is happening to me. If this has happened now, another next negative is going to happen, then another negative is going to happen. and which is leading to all the impact on my, which is negative. So my disease is not going to get cured and I'm going to die soon, which impacts emotionally so much that I withdraw myself. I have a lot of fear, anxiety, and increase in my depression, which lowers my mental health and my treatment outlook, or my outlook towards my treatment is hampered, because now I only see my disease is leading me towards death. Whatever treatment I'm getting is of no use, or is of no use any person. So I rather do not adhere to the treatment and focus only on, let's say, towards my terminal side. Next slide, please. Now, how to mitigate such things? Here, healthcare providers and patients' awareness really plays a real big role. First is provide clear and reassuring information. As a healthcare provider, we must provide them with right kind of information, with proactive communication. We motivate our patients to communicate very clearly whatever their concerns are, whatever their goals are, with the goals of what goals they have come in with for the treatment. If there is, let's say, unreasonable hopes they are having, which we may not be able to sort at a very short time. So we let them adhere to and develop new short-term goals, so that they can actually see their treatment with a positive viewpoint. But that can only happen with the proactive communication being developed with patients and attendants. We talk about their anticipated concerns. What are their concerns? What are they thinking about? All the scenarios they have in their head, so that we can sort them out. We encourage the use of trusted sources. We understand that a person will search for the information. So, as healthcare providers, what we can do is we can provide them with trusted websites which they can receive, which they can go through. For example, I've quoted here Mayo Clinic, National Cancer Institute website. We have a number of websites available which do have appropriate kind of knowledge and information which is correct up to the mark. We can also provide them educational material which we have with them about their disease, about whatever chemotherapy or treatment they have to undergo, so that they are going through some verified materials which is applicable on them. We have to foster open and empathic communication with them. We must encourage patients and attendants as well to ask questions. They have questions. Instead of letting them ask their questions online, we must encourage them to ask us. We must develop that trust with the patient and attendant that yes, they're free to ask whatever they have in them. Instead of searching online and on unverified resources or sources, ask us, so that we can tell them what is or whatever is pertinent to them, pertinent to their disease, their level of disease, and their treatment only. Then we must educate patients on digital literacy. Now, tech critical evaluation has to be done. Red flag warning should be given. So, whatever they go through internet, and they will, whatever kind of knowledge, educational resources we are going to tell them or give them, they will still search on internet about something or other. Or at times, what happens is my relatives or my friends have been telling me that I have gone through this. See, I've shared a link with you. Go through it. So we have to raise red flags that do not believe on unverified sources. But just in case if you have gone through something, do ask us whether that is applicable on you or not. Then provide psychological support. It is really important. At times, this mental health part is, let's say, being avoided either by a clinician or by the patient themselves because of the stigma attached to this society. But counseling referral should be done at the right time. Counselors or psychologists can actually attach patient and attendant to the right support groups. We have a lot of support groups nowadays related to this field. So the right attachment can actually enhance their outcome, which is needed at this point. Next slide. Thank you so much for your patient hearing and giving me due time.
Good afternoon all. This is Dr. Praveen from India. Hope you all are doing well. So I am consultant radiologist working from last 9 to 10 years, and my expertise is in imaging modalities like MRI, CT, ultrasound and X-rays. Okay, so what is that we are expecting from this webinar? Desmoid. How do we diagnose a mass as a desmoid, and how do we differentiate it from other masses? What are the things which are to be kept in mind for diagnosing a desmoid tumor? So why don't we start with our case history? So this is the case of a 32-year-old non-pregnant female of Asian origin who presented with progressively enlarging lower abdominal mass from last 3-4 months, and she had history of cesarean about 3 years back. However, there was no significant family history. So let's start with the scan. This is the axial T2-weighted image, and we can see a large heterogeneous mass which is occupying almost whole of the right half of pelvis, and it is causing contralateral shift of urinary bladder. And we can see with this thick white arrow that ovarian tissue is seen along the posterior aspect of the mass, and anteriorly it is causing quite a bulge in the anterior abdominal wall without any obvious fat planes between the two. Moving on next, here we can see that these are axial T1 images without fat suppression and with fat suppression. In this, the mass is totally T1 hypointense. There is no T1 hyperintense component within the mass to suggest any fat, hemorrhage, or proteinaceous component. On diffusion weighted images, you cannot appreciate any foci of diffusion restriction within the mass. On CT correlation, we cannot see any foci of calcification or fat within the mass. So, looking at the images of the mass, what do we get? What are the possibilities on the first look? It could be a large abdominopelvic lesion mass arising from right adnexa or ovarian tissue, or it could be a pathology arising from uterus like large pedunculated subserosal leiomyoma or broad ligament leiomyoma with cystic degeneration. So, how do we rule in or out these possibilities? Let's start with the leiomyoma. Let's try to find some connection of the mass with the uterus. So where is our uterus? This is again axial T2 weighted image. In this, we can see that this is the uterus and it is lying well away from the mass, and right-sided fallopian tube and round ligament structure are clearly visualized. So obviously we cannot see any obvious connection between the uterus and the mass. So possibility of leiomyoma seems to be little less likely. So what's the other possibility which we have put forward? That's the ovarian mass. So This is a solid cystic mass, ovarian masses, which are solid cystic type. They are more towards malignancy, and which is the age group in which sporadic ovarian masses or malignancies are known. That's the elderly population. But however, there are a few exceptions. Let's discuss them. The ovarian tumors in young, the most common type being mature teratoma. What's a classical feature of mature teratoma? That it's got fat. And as we have seen the images, we could not find any fat component within the lesion. So possibility of teratoma also seems a little less likely. Another possibility could be yolk sac tumor, which is also solid cystic type. It should show some hemorrhagic component, but that should also be T1 hyperintense or can also be picked on CT. So this possibility is also less likely. Another is Sertoli Leydig cell tumor, which is also solid cystic type. So, but if we are considering this possibility, it should show some signs of androgen activity like mescalization, deepening of voice, etc. Another possibility of ovarian tumor in young is, which is predominantly solid, is dysgerminoma because it's got predominantly fibrous component. So we can consider it. Okay, so let's look at our scan again. What do we see? Let's look at the interior abdominal wall. We can see that this right rectus abdominis is quite reduced in bulk as compared to the left hand side. So could it be so that this could be the origin interior abdominal wall? Let's check out other planes too. So this is this sagittal image, axial T2, sagittal T2 weighted image. In this we can see that the rectus abdominis is pretty much thinned out and it is kind of forming a Y. It seems like that it is splayed by the mass. It is forming a Y and the mass is in between the limbs of the Y, like it is kind of originating from the rectus abdominis. So, can it be so? Can we add some other differential to our list? Yes, we can. This could be a mass or tumor of abdominal wall origin. And what are the abdominal wall masses? They are rare heterogeneous diseases with desmoid tumors being the most frequent ones. Okay, so what are the points which are favoring desmoid tumor in our case? This is female of reproductive age group, 32 years. Yes, she is. And she has a previous history of any surgery. Yes, she has history of cesarean section previously. And she has presented with a large abdominopelvic mass with possible origin from rectus abdominis. Yes. So possibility of abdominal wall desmoid tumor can be put. So this is the image which is showing the old scar post LSCA scar. So how do we rule in or rule out desmoid and ovarian tumor and vice versa? Let's compare the two. This is the ovarian tumor. If we talk about the incidence, definitely the incidence of ovarian malignancy is more as compared to desmoid, which is about 3.6 percentage, and desmoid incidence is only 0.03 percentage. And one of the very important risk factor for ovarian malignancy is nulliparity. However, our case, she is a post LSCS patient. So this is ruled out. So in desmoid, the risk factor is of any previous surgery, or if we specify it post LSES. And what's the age group which is affected in ovarian malignancy? It is mostly the older women, with few exceptions, which we have already discussed. And age group affected in desmoid is women of reproductive age group, because desmoids tend to develop during the pregnancy or within few years of LSCS. So, coming to our case, what happened? The patient underwent exploratory laparotomy, and during the procedure, the mass was found to be attached to the abdominal wall and free from the uterus and the ovaries, which confirmed its abdominal wall origin. So these are the intraop pics. In this, we can see that this is large mass and this is small stalk, which is showing the attachment of the mass to the abdominal wall. And on right, we can see the gross specimen, 16 centimeter sized reddish brown mass with firm consistency. On microscopic findings, multiple spindle cells were found in sweeping fascicle, which confirmed the diagnosis of fibromatosis, as we can see in this multiple spindle cells. So, let's talk a little bit about what are desmoid tumors. They are rare fibrous tumors of soft tissue which constitute about 3% of all soft tissue tumors and 0.03% of all the tumors. What's special about them? They have strong tendency for local invasion and recurrence, and the metastatic potential they do not have. They can be intra-abdominal, within the abdomen, mesenteric, but they are mostly syndromic, associated with syndromes like Gardner, FAP, that is familial adenomatous polyposis, and second is within the abdominal wall, pregnancy-associated desmoids, as in our case. And third is the extra abdominal, which could be head and neck, in the chest wall or in gluteal region, and they are also intimately associated with muscle and fascia. So, our case, pregnancy related desmoid tumors. Why do desmoid tumors develop in pregnancy? Few reports find that they show significant estrogen receptor expression, and some desmoids even respond to anti estrogen treatment. According to some authors, the trauma experienced by the abdominal wall during the pregnancy are the triggering factor towards desmoid development, obviously in a predisposed female. After the microtrauma may be occurring due to pregnancy or may it be due to any surgery, the healing process starts, and the mesenchymal cells, which are pluripotent cells, they come and they differentiate into fibroblasts, myofibroblasts, and it is a very complex mechanism which ultimately lead to desmoid tumor formation. Abdominal wall desmoids are usually very large masses. They can vary from 5 to 15 centimeter, and there is a long list of differentials of rectus abdominis masses, which is acute hematoma. We could have ruled it out on MRI only according to the signal intensity on T1, T2. There could be sarcomas, various sarcomas, fibrosarcoma, rhabdomyosarcoma, liposarcoma, leiomyosarcoma. Since these are sarcomatous, there's a possibility it has got more cellularity, more mitotic activity. So there's possibility we could have found some foci of diffusion restriction in these cases. Other differentials are lymphoma, neurofibroma, benign fibrous tumor, and PNET, primitive neuroectodermal tumor. But the very important thing is that there is no specific imaging feature to differentiate desmoid from these other solid masses. You have to consider the diagnosis of desmoid considering the patient's history very importantly. Female of reproductive age with the abdominal mass and any previous history of surgery or even injury, you can put the diagnosis of desmoid, because the definitive diagnosis is always established with a histopathological analysis. So, there is one more important differential, that is endometriotic tumor. But how do we differentiate? First of all, clinically, correlate the symptoms with the monthly periods, the volume and the pain with the monthly periods. Of course, on MRI, we can find some T1 hyperintense areas for in case of endometriotic tumor because of the blood components. So pre-surgically, we can differentiate between these two entities. And what's the treatment? Take it out. Wide local excision with reconstruction of the defect. And in case of inoperable tumors, local recurrence or incomplete resection, radiotherapy can be considered. What's the recurrence rate? Yes, they tend to recur. This is their kind of salient feature. The recurrence rate can go up to 77%, but it depends upon the location and extent of tumor. In case of abdominal wall desmoids, they have relatively low rate of recurrence, which is from 20 to 30%. And distant metastasis, it never occurs in desmoid tumors. So, what's the take home message? That large sized desmoid tumors may be misdiagnosed, and they have been misdiagnosed for leiomyoma or other abdominal or pelvic tumors, especially the ones with large intra-abdominal component. Therefore, a detailed history and on MRI looking properly for the origin of the large abdominopelvic mass is very important. They are the key to diagnosis. Okay, so I'm very thankful to the organizers for giving me the opportunity to speak on this large platform, and thank you to my listeners.
So, I'm here, a consultant medical oncologist at AIIMS Bhopal, and this study was done at my previous center, Kidwai Memorial Institute of Oncology. So the topic of my study is frequency of programmed death ligand receptor 1, that is PDL1 expression, and clinicopathological factors associated with metastatic triple negative breast cancer. Beginning with the introduction, globally, breast cancer is the most common cancer amongst females in terms of incidence as well as mortality, and triple negative breast cancers is a very deadly disease. This, thankfully, it is low at 15%. And even in low and middle income countries, it is more. It is almost 30%. And it's very common among young females and associated with aggressive biology and low survival rates because of the natural history of the breast cancer in triple negative disease, which is associated with early visceral metastasis. Chemotherapy has long been the only available treatment option in this group, and patients with PDL1 expressing tumors can now get immunotherapy along with chemotherapy. TNBC express a higher frequency of intratumoral lymphocytes and PDL1, that is programmed cell death ligand 1. It is basically a signaling pathway in which PD1 and PDL1 protein, they signal and they apply brakes to the immune system. So this is what we want to overcome. And coming on to the results, the reports have been few reports have been reported about PDL1 expression in breast cancer, and these are controversial because of the use of different antibody clones, various scoring systems, and evaluation in lymphocytes and neoplastic cells. So PD1 and PDL1 is a rapidly evolving area. Herein, I have mentioned two drugs. The first one is atezolizumab, which was introduced because of overall survival advantage in the IM Passion 130 trial. However, later with IM Passion 131 coming, it showed that this drug was in fact detrimental. So it was later on withdrawn. And coming on to the second drug, pembrolizumab, it is approved in neoadjuvant and metastatic setting now. Beginning with materials and methods, this is a prospective study which was carried out in the Department of Medical Oncology at a tertiary care center in South India after having approval from Institute Ethics Committee and informed consent from the patients. and case records of all the breast cancer patients who were treated with chemotherapy in 2 years between August 21 and July 23 were reviewed. And the patients with metastatic TNBC were selected because at that time, only pembrolizumab was indicated in metastatic setting. The study included all adult female cancer patients with histologically confirmed TNBC and metastatic disease. And those who were excluded were male breast cancer patients, younger patients less than 18 years, and those who were not willing to give the informed consent. Antibody staining of a set of paraffin blocks was done for ER, PR, and HER2 for each of the patients. An IHC score of 3+ on IHC was regarded as positive. For 0 or 1, it was negative. And for IHC score of 2, we did a FISH test. Any breast cancer patients that had shown signs of distant metastasis clinically was later confirmed by radiologically and was classified as metastatic breast cancer. PD-L1 was investigated using the 22C3 IHC test on the intratumoral immune cells. And we gave a score of immune cells, that is immune cell score. All the immune cells are located intratumorally as well as in a small peritumoral stromal rim are considered to calculate the positive IC score. It is evaluating the percentage area occupied with all the PD-L1 positive immune cells, including macrophages, lymphocytes, granulocytes, and dendritic cells related to the whole tumoral area, neoplastic as well as tumor stroma. Coming on to the results, during the study period of 2 years, 968 breast cancer patients were registered at our institute, and out of these, 208, that is almost 21%, were triple negative breast cancer. Further, out of 208 TNBC patients, 57% were metastatic, and case reports were not available for 2 patients. Hence, a data of 118 patients was analyzed for this study. The median age of presentation was 46 years, and the age ranged from 36 to 65 years, while the majority were premenopausal at 52.5%, as it is very well known that TNBC presents in young females. So these are the baseline characteristics of my study population. Median age was 46 years, range being 36 to 65 years. A majority were premenopausal at 52.5%. A family history of breast cancer was seen in nearly 22% of the patients, and majority were left-sided. Coming out of the side of metastasis, majority had visceral metastasis. The histology was IDC, as it is very well known from the other studies, and it was metaplastic carcinoma, which was 1.7%. The other grades of the tumor also has been depicted in the study here. Yeah. So here I am showing the histopathological evaluation, which is showing the neoplastic cells arranged in sheets and nests. As first line of chemotherapy, anthracycline-based chemotherapy was administered to the majority, that is 54.2% of the patients. Taxane-based chemotherapy was given to 37% of the patients. And there were a few patients who were planned for radical intent because of the oligometastatic disease. And for them, anthracycline and taxane-based chemo was given. This was around 10%. PD-L1 expression using IHC was using a combined positive score of 10 was seen in 32% of the patients. And the difference between PD-L1 positive and negative is shown in table 2. So here we see that the patients who were PD-L1 positive were 80, 38 were the PD-L1 negative were 80, the majority of them, while PD-L1 positive was 38 and 118 patients. The age group was almost similar, but there were more patients in the age group of 40 to 50 years in the PD-L1 positive population. PD-L1 negative also had very young females which were less than 40 years, that was 27.5%. There was no difference in the premenopausal or postmenopausal status. Coming on to the Ki-67 index, for PD-L1 negative patients, the Ki-67 in majority was 20 to 40. Again, in the PD-L1 positive, also the majority of patients were in the PD-L1 in Ki-67, 47%. 20 to 40, and these were 47%. Now, apart from this, there were no other significant differences in the two. And this is the survival curve, the Kaplan-Meier survival, that depicts the survival of the study population at 12 months. Here we can see the median survival was 10 months. And the survival was associated with menopausal status and family history, while the survival was not associated with PD-L1 and sidedness in our study. Estimated survival at 12 months in PD-L1 negative cases is 10 months plus minus 0.29, while in PD-L1 positive, it was slightly more at 10 plus minus 0.75 months. But the value is very near and it's not statistically significant. Now, beginning with the discussion part. So the incidence of TNBC in our study was 32.2%. As with the previous researches, IDC-NOS was the most prevalent histology, and 31% of patients, that is 38 out of 120 of the patients, had PD-L1 positive expression in the tumor. The percentage ranged from 30 to 60% in the scant literature that is currently accessible, and various Indian studies show PD-L1 expression ranging from 13% to 59%. Here we can see the various studies of PD-L1 positive breast cancer in various parts of India. Our study showed it to be 31.66%, while there was another study again from South India that showed PD-L1 positivity to be 52% in immune cells and 13% in tumor cells. Ghosh et al. Did not specify the PD-L1 positivity because they had used some other tests, but Ventana SP142 is the platform. And Sharma et al. Showed 32.5% PD-L1 positivity in tumor cells. Mehan et al. Showed 59.2% in tumor cells and 37% in tumor cells. And Punani et al. Reported PD-L1 positivity at 14%. So the median survival was 10 months in our study. Survival was associated with menopausal status and family history, and there was no association found between survival as well as PD-L1 and sidedness. Estimated survival at 12 months in PD-L1 negative case was little lower than the PD-L1 positive, but the difference is not statistically significant, and it's not very clear in the literature as well if the PD-L1 positive status is associated with a survival which is worse or improved. However, according to the prior research on breast cancer by Sharper et al. And Botti et al., PD-L1 expression was associated with improved disease-free survival but had no effect on overall survival. However, a few meta-analyses suggest a worse overall survival and no association with disease-free survival. A major limitation from the previous studies in India is that they have been carried out in the Department of Pathology, so the patient characteristics were not analyzed in detail and with respect to clinical characteristics. As per our knowledge, PD-L1 status was not analyzed with respect to survival in India by any of the previous studies. The results among the metastatic TNBC were not so accurate as hormone receptor positive cases and HER2 positive cases were also included. Apart from this, about the extent of disease, majority of patients had loco-regional disease rather than being metastatic. Along with this, the platform used in most of the studies was SP142 assay, which itself has the limitations in the form of percentage positivity, as shown in the previous Blueprint 2 study. Atezolizumab for which SP142 was approved as companion diagnostics, has been withdrawn as we discussed in the introduction part. And our study has a limitation that it's a single center study and considering the small sample size. So beginning with the conclusions now, among the patients with metastatic triple-negative breast cancer, PD-L1 expression in immune cells was seen in 32.2% at our center. The median survival was 10 months, and survival is associated with menopausal status and family history. Premenopausal women and those with positive family history obviously have a poor survival. Association between PD-L1 and survival was not seen. For pembrolizumab therapy in patients with metastatic TNBC, PD-L1 testing is needed with DACO22C3 companion diagnostics, whereas atezolizumab that required testing with PD-L1 with the platform Ventana SP142 has been withdrawn. This was used in the previous test because atezo was the first immunotherapy that was indicated in breast cancer historically. So PD-L1 testing is not required for localized breast cancer in the neoadjuvant setting. And as the field of immune checkpoint inhibitors and the role of PD-L1 assays is dynamic, there should be more studies in this area. On IHC, the assessment of PD-L1 positive immune cells using the IC score should be reported wherever feasible, considering the logistics. And there may be differences in PD-L1 percentage positivity in the Western and Indian population, so the immunotherapy drug usage implications may be varied. These are my references. Yeah, so this is all from my side. Thank you.
So hello everyone, it's a pleasure to be here and speak with you. My name is Sabah Ahmadi and I'm a physician from Tbilisi State Medical University, and I conduct research in cervical cancer and breast cancer. Specifically, I'm interested in genetics and immunology of cancer. So this presentation is about interleukin-10 polymorphism and breast cancer risk in Georgian women. It is a case control study. First, I'd like to mention that this study was funded by the Shotorostoveli National Science Foundation of Georgia and was approved by the Ethics Committee of Tbilisi State Medical University in Tbilisi. So, as you know, breast cancer is the #1 diagnosed cancer malignancy in women, and in the year 2020, there were 2.3 million new cases and 685,000 deaths worldwide associated with breast cancer. So you can see that breast cancer is has the highest occurrence in women with 26%, and then lung cancer comes after with 14%. And in case of mortality, breast cancer falls under lung cancer. So today, 5 to 10% of all breast cancer cases are caused by known germline mutations, and these known germline mutations are divided into high-risk genes and low to moderate risk genes. High-risk genes are genes that we are very familiar with as physicians: BRCA1, BRCA2, PTN, TP53, LKB1, STK11, and CDH1. And low to moderate risk genes are genes like CHEK2, TGF-beta1, CASP8, and ATM. However, currently, most of the breast cancer cases that are diagnosed in clinics are categorized as sporadic cancers. And it is very likely that these sporadic cases have low penetrant genetic polymorphisms that are involved in their development. So, as you know, human immune system has advanced ways of averting cancer development, but also neoplastic cells employ different strategies to evade immune detection. And one of these strategies is producing immunosuppressive factors that dampen the function of T cells, dendritic cells, and natural killer cells. Some of these immunosuppressive factors are nitric oxide, interleukin-6, interleukin-10, tumor growth factor beta, indolamine 2,3 deoxygenase, arginase 1, prostaglandin E2, vascular endothelial growth factor, and cyclooxygenase 2. So among these factors that I mentioned is interleukin-10, which was the focus of our study. And interleukin-10 can impede the function of CD4 and CD8 T cells and promote immunosuppressive cells like T regulatory cells, so Treg3. That causes promotion of cancer development and progression. For example, in the case of infection with high-risk HPV strains, immunosuppressive properties of interleukin-10 has been proven to play a role in the facilitation of facilitating evasion of immune response by HPV virus. So, I mentioned that interleukin-10 can cause promotion of cancer with dampening the function of immune cells. However, the role of interleukin-10 in cancer is not so straightforward. Its expression has also been linked to downregulation of major histocompatibility complex class 1 expression on the cell surface. And when MHC class 1 expression is low on cells, that means natural killer cells will detect these cells and lead to lysis of these cells. So basically, natural killer cells can kill these tumor cells when they have lower HC1 expression. And the study on the effect of interleukin-10 on melanoma showed that interleukin-10 can inhibit macrophage-derived angiogenic factors and probably act as an antimetastatic agent. So you can see interleukin-10 can have opposite effects. It can help the cells evade immune cells, dampen the function of CD4 and CD8 cells, but also it can lead to natural killer cells detecting tumor cells more and leading to the lysis of tumor cells, and also inhibit angiogenic factors and be an antimetastatic agent. So totally opposite effects. So conclusion is that IL-10's role in cancer is not very much understood, and it's not very straightforward. So due to this conflict, it's important to study interleukin-10's role in cancer. So the gene that produces interleukin-10 is located on chromosome 1, and there is a single nucleotide polymorphism in its promoter region, specifically in location 1082, that causes an A to G change. And this A to G change causes alteration in its expression, and hence it can change the susceptibility and progression of cancer. So how is that? There is a nuclear protein that physically interacts in an allele-specific manner with the promoter region of interleukin-10. And this nuclear protein is poly-ADP ribose polymerase 1, or PARP1. And PARP1 is a transcription repressor, and it prefers to bind the A allele instead of the G allele. And this difference results in less expression of interleukin-10 in people who have the A allele. So to summarize it for you, some people have the A allele and some people have the G allele. And those people who have the A allele will have less expression of interleukin-10 because this nuclear protein prefers, which is a transcription repressor, prefers to bind the A allele. So our research objective was to investigate the association between interleukin-10 1082 A to G polymorphism and the risk of developing breast cancer in Georgian women, and to further examine this association between proliferative activity and the investigated SNP, or single nucleotide polymorphism. So we recruited breast cancer patients and healthy controls, and our inclusion criteria were as followed: the age range of 30 to 80, ability to understand the purpose of the study and provide informed consent, female sex, and being ethnically Georgian. You might wonder why we specifically wanted to exclude other ethnicities and only focus on one ethnicity. And the reason is that the frequency of SNPs in different ethnicities can be totally different. And it's important for studies and smaller studies to focus on one ethnicity to decrease the confounding variable, which is ethnicity. So, for example, people from another country can have a different distribution of that polymorphism in their genes. So the cases were also required to have a biopsy-confirmed diagnosis of breast carcinoma with no previous history of breast surgery, preoperative chemotherapy, or radiation therapy. So after patients and controls were recruited, DNA was extracted from the whole blood, and with real-time PCR and Tachman assay, SNP genotyping was performed, and then statistical analysis was performed. So in the cases, meaning breast cancer cases, the frequency of AA, AG, and GG genotype were as follows: 29%, 59%, and 10%. And then for healthy controls, we had 35.9% of AA genotype, AG was 54.6%, and GG was 9.37%. As you can see, these percentages are very close, and you would be right in thinking that there was no statistical significant difference between these two study groups. So we calculated odds ratio and chi-square, and the p-values were not statistically significant, meaning that between the cases and their controls, there was no statistical difference between the genotypes and between the allele distribution. So in our breast cancer patients, we had the following characteristics. 31% had the proliferative activity of more than 30%, and 68% had proliferative activity less than 30. HER2 positivity was in 17.7% of patients, ER positivity was in 71.1%, and PR positivity was in 68.8%. So patients' proliferative activity was compared with an unpaired t-test between the two groups of AA and AG and GG. So basically compared with between groups who had the G genotype or didn't have the G genotype. Mean proliferative activity in patients with AA genotype was 20.7%, and in patients who had the AG or GG genotype was 19.3%. And there was no statistical significant difference between the proliferative activity of these two groups either. So even though there was no statistical difference between their proliferative activity, however, if we put these proliferative activity in box and whiskers plot, we can see that there are obvious outliers in patients who had the G allele. So extreme proliferative activity was seen in patients with the G allele, and that means a worse prognosis. So proliferative activity was measured by Ki67, which is a monoclonal antibody that recognizes proliferating cells, and the higher it is, the worse the prognosis. And you can see the outliers had extreme proliferative activity and poor prognosis. So this SNP has been studied in different populations and different malignancies, but the results have been conflicting. In melanoma and prostate cancer, the genotype with less expression of interleukin-10 were a risk factor. However, data in breast cancer is way more conflicting. But our findings are in accordance with two other studies that were performed in Chinese and Iranian population. So in conclusion, this study showed no real association between the 1082A2G SNP and breast cancer risk in Georgian women. However, it's important to note that much larger studies, including different ethnicities and studies combining genotype and gene expression, are required to improve our understanding of the role of interleukin-10 in cancer development. One major limitation of our study is that we do not have the gene expression, but only the gene study and the genotype study. Having gene expression and comparing the phenotype, which is basically the level of interleukin-10 in patients' blood, would help develop more data and more understanding on the role of interleukin-10 in cancer. Thank you so much.
How about my presentation? I'm starting.
Yeah, we can see you.
I want to present to your attention in continuation of the molecular genetic research of cancer. Today, a report dedicated to such complex and sufficiently studied diseases as ovarian cancer. Some word about me. I am a gynecological oncologist who has been working in this field for about 20 years. Molecular genetic parameters in ovarian cancer are of my greatest scientific interest since 2014. And we all know that ovarian cancer is a heterogeneous group of malignancies. High-grade serous carcinomas is the most common type of epithelial ovarian carcinomas. They are characterized by its aggressive nature, with around 18% of patients being diagnosed with advanced disease. And there are a lot of questions for discussion. This is due to the complexity of pathogenesis of ovarian cancer. Also, although most of patients respond to initial treatment, most of them relapse, resulting in more aggressive disease, development of chemoresistance. Patients are doomed to have their illnesses progressing. There are critical problems, the problems of heterogeneity and the problem of resistance. At the same time, greatest importance of understanding these problems lies in the study of the microenvironment. There is a cellular environment in which the tumors resides, including surrounding blood vessels, immune cells, fibroblasts, other cells, signaling molecules, and others. There is an urgent need to understand better the tumor microenvironment in general and its distinct components in particular. The research of ascitic fluid is important to study the tumor microenvironment in ovarian cancer. The pathogenesis of ascitic in ovarian cancer is complex. The fluid contains tumor cells, non-tumor cells, circulation-free DNA and signaling molecules, subgroups of patients with low volume of ascites and large volume of ascites are different groups in high-grade ovarian carcinomas. There is a the subgroup of patients with low volume of ascites is characterized by activation of immune-related genes and tumor infiltration cells. A study of the transcriptional and mutational landscape of cancer cells isolated from malignant ascites confirms the existence of several clusters enriched genes associated with cancer development, tumor host response, and stemness. We can talk about the untapped potential of ascites in ovarian cancer. Once we focused our attention on studying the factors of the insulin-like growth factor system and the proteolysis system, both of these systems are interconnected with resistance, prognosis, and survival. We studied them in tumor tissue, in metastatic tissue, and in ascitic fluid. And we studied some of them, namely proteolysis system, proteolysis components in vesicles, exosomes of ascitic fluid and plasma. In a group of patients with high-grade ovarian cancer, we studied these parameters, insulin growth factors, their bounding proteins, and insulin-like growth factor receptor type 1 and metalloproteinase, PAPP, as well as the level of activity proteasomes and calpains, including in exosomes. We studied the parameters before and after neoadjuvant chemotherapy, and we used the methods shown on the side on the right. We examined these parameters in ascitic fluid compared with the primary tumor and metastasis, and high levels of insulin growth factors and their bounding proteins were detected in the cell-free part of ascitic fluid compared with the primary tumor and the metastasis, regardless the course of ovarian cancer variants, the ascitic fluid volume, and the BRCA gene's mutational status, which is likely due to peritoneal metastasis. We examined the levels depending on the course of ovarian cancer variants. Resistant and refractory variants of the course of ovarian cancer are accompanied by the increase of the level of insulin growth factor bounding protein 3 in the ascitic fluid after neoadjuvant chemotherapy compared to the initial values. We examined the protease activity and metalloproteinase expression depending on the severity of ascites. The activity of 26S proteasomes and the total activity of calpains in the primary tumor tissue are reduced, and the expression of metalloproteinase is increased among the patients with a significant volume of ascitic fluid compared with the patient whose ascitic fluid volume is less than 200 milliliters. In addition, we studied extracellular vesicles, exosomes in ascites, assessing their protease activity. Exosomes of ascitic fluid and blood plasma of the patients with high-grade ovarian cancer compared with the patients with borderline ovarian tumors contain significant amounts of 20S proteasomes which do not have chymotrypsin-like activity. The level correlates with the volume of ascitic fluid, and the level of 20S proteasomes in ascitic exosomes is significantly higher among the patient whose ascitic fluid volume is less than 200 milliliters than in patients with severe ascites. We found the connection with survival rates and level of insulin growth factor 2 in ascitic fluid were associated with overall survival rates at the second and first years. Thus, the molecular genetic components of ascitic fluid have a relationship with the prognosis of high-grade ovarian cancer and may be a particular interest for further research. Ascitic fluid is an attractive biological material for searching for molecular biomarkers characterizing the tumor microenvironment in ovarian cancer. The levels of parameters of the insulin-like growth factor system and the proteolysis system depend on the volume of ascitic fluid and are associated with the course of the disease. And the insulin-like growth factor 2 and the bounding protein 3 are parameters of ascitic fluid that have the greatest prognostic volume. I want to thank you for attention, and will conclude my speech with word of the great Russian singer and poet Vladimir Vysotsky. There are no reason to stop, I'm sliding, and there are no such peaks on the board which you can take. And again, thank you, dear colleagues. Thank you very much.
Good afternoon to the Honorable Mr. or Mrs. Chairman of the committee and all of audience who has come in this event. It's a pleasure to be here, and I would like to say thank you for the opportunity that given to me. Let me start. As we can see on the screen, my topic is unraveling the causes of microbleeding in Alzheimer's patients with deep vein thrombosis, exploring the role of cerebral amyloid angiopathy and the impacts of NTA accumulation due to renal clearance decrease. My case report, an 80-year-old Indonesian woman diagnosed with Alzheimer's disease and deep vein thrombosis or DVT, admitted to the neurobehavior clinic on May 16th, 2023. Microbleeding was detected in the right cerebellum, right occipital lobe, left caudata nucleus, and left-right frontal cortex based on the brain MRI, as we can see on figure 1. The patient had been treated with NTA like rivaroxaban, 15 milligram twice a day since April 17, 2018, sorry, due to DVT. The diagnosis of probable Alzheimer's dementia with immobilization was made on June 13, 2017. Laboratory findings on November 21, 2023 reveal an eGFR of 36 milliliter per minute per 1.73 meter square, indicating a moderate to severe decline in kidney function. For introduction, Alzheimer's disease is the most common cause of dementia. As we know, this is a progressive neurological disorder that primarily affects elderly, gradually leading to memory loss and cognitive decline and changes in behavior and personality. However, as the disease progresses to late stage, it can lead to difficulties in movement and coordination, which may resemble motoric impairment. These motoric symptoms can include problems in walking, balance, and coordination, but they are not the primary features of the disease. Deep vein thrombosis or DVT is a condition where blood clots form in the deep veins of the body, typically in the legs. These clots can be dangerous because they can break loose and travel through the bloodstream, potentially causing blockade in vital organs like the lung as pulmonary embolisms. Therapy for DVT usually involve anticoagulant, commonly known as blood thinners, to prevent extension of the clot and to stop the new clot formation. This medication may include heparin, warfarin, or newer oral anticoagulants such as rivaroxaban and apixaban. In some cases, more aggressive treatments such as thrombolytic therapy or surgical procedure may be necessary to dissolve or remove the clot. Additionally, compression stocking and lifestyle changes such as regular exercise and avoiding prolonged periods of immobility can also help manage DVT. For discussion, Alzheimer's disease is a multifactorial syndrome marked by progressive changes in brain parenchyma. Result of basic research show a contribution of cerebrovascular dysfunctions. Protein of amyloid beta, thrombin, and fibrin are key drivers in triggering vascular abnormalities known as cerebral amyloid angiopathy or CAA, which can result in clot formation in brain parenchyma and around cerebral blood vessels. The result of deteriorated blood flow and degradation clearance of amyloid beta leading to amyloid beta accumulation, microglia activation, synaptic dysfunction, and neuronal death. Decreased cerebral blood flow causes hypoperfusion, cerebral microvascular infarction, and microhemorrhage or microbleedings. Direct oral anticoagulants are proposed to counteract amyloid beta-induced pathological changes in cerebral blood vessels. Direct thrombin inhibitors and NTA are referred to as DOACs. The compromised kidney function found in these patients raises concerns on the clearance of NTA and potential adverse effects, including brain bleeding. Therefore, microbleeding found in this patient might be consequence of Alzheimer's pathology and or adverse effect of NTA. In conclusion, Alzheimer's dementia can cause CAA, which can lead to microbleeding in the brain in elderly patients with Alzheimer's dementia. Immobilization often results in DVT, which is treated with NTA. However, drug accumulation can occur due to decreased kidney function, which in turn can cause microbleeds in the brain. This case report aims to analyze factors that may contribute to the pathophysiological mechanism underlying microbleeding in Alzheimer's patients with DVT, thereby paving the way for appropriate therapeutic interventions and improve patient outcomes. That completes my presentation for today. Thank you for your time.
Thank you very much for inviting me to this conference. It's a pleasure to be here, and I have to share my screen probably.
Yes, please.
Something wrong. Sorry. Have to select. Is it better? Can you see it?
We can see it, but it's quite small. Could you put it in full screen?
I think that the size is different. It's not a rectangle, it's vertical. That's the problem. So I will just scroll down when I'll be speaking. Is that okay?
That's not an issue, but could you at least put it in full screen, even if it's vertical, because it's quite small?
Full screen. Where is full screen?
Can we share it from our side?
Yes, if you want to.
Okay.
Okay. I'll try to speak, and if there is some noise, no, that's okay. Can you hear me?
Yes, doctor, we can hear you.
Okay, so I'll start. So I am Alexandra Corelli. Actually, my background is I'm a nurse, a perioperative nurse, and at the moment I'm teaching at the University of West Attica nursing department as a professor in perioperative nursing. And this one study was a project between the University of Crete and the colorectal department of King's College Hospital. So the study was about factors affecting patient decision-making in choice of transdermal endoscopic microsurgery treatment for rectal cancer patients. And patient involvement in treatment decision is fundamental in modern health care and known to be beneficial to patient treatment experience. And the aim of our study was to explore the factors affecting patients' decision-making concerning the choice of transdermal endoscopic microsurgery treatment. And this study is cross-sectional. Please move it down. So, cross-sectional study of patients with rectal cancer stage T1, T2, no nodes, no metastasis, who underwent TEMS. The patient's views on experience and treatment decision were obtained with a custom-designed questionnaire, and general quality of life was assessed with SF12, generic questionnaire on quality of life, and specific bowel function was assessed with Webster score. As for sexual functioning, we assessed it with sexual functioning questionnaire. Can you just please scroll a little bit down? That's okay. Back again, up. I'm going to results, which are on the right side. Little bit up. No. Upward. Yeah, thank you. Even more. Even up. Okay. So our results were that 34 patients completed the questionnaires, which were analyzed. We had males 22 out of 34 patients with age mean around 76 years old, and follow-up time mean was 7 years old, the longest in the bibliography. The factors that influenced the patient's decision were experience satisfaction, postoperative bowel function, or incontinence score at present, and the agreement of TEMS experience with preoperative information. That was the question, which side would you have the TEMS surgery again in a similar situation? So if the response was that yes, I could, we just correlated with a few factors. And about treatment experience satisfaction, that was associated with family support and the agreement with preoperative information. The preoperative information was if the patient were agreed that their experience was according to what they've been told before. And this one experience correlated also with bowel function, and we are speaking about the current functioning and mental quality of health. Both physical and mental quality of life were similar to the general population. There was no difference, and were inversely associated with the level of continence, which been shown by Wexner score. Actually, the score, the continence level in our patients was quite good. It was 3.97, the mean. And sexual functioning overall was correlated with better physical quality of life, and in reverse with increasing age. Patients reported less problems, sexual problems, when having better mental health, and postoperative pain was rated low. On a scale of 0 to 10, the mean was 3.1. The less postoperative pain was associated with family support in our patients. So our conclusion actually is that factors important to patients when they're reflecting on treatment experience of TEMS are adequate and reliable information. First, a good quality of life in the following, and the presence of family support. So when we incorporate those parameters in our practice, then probably we will have a better result. On the left, you can see the figure. It's much better shown there that decision is primarily connected to agreement and experience, to terms experience, to bowel function, and to weakness score.